Okay, I'm Ms. Hahn, and I am going to go over Chapter 24, Nursing Management of the Newborn at Risk, Congenital and Acquired Newborn Conditions with you today. So, our learning objectives for this chapter include upon completion of the chapter, you will be able to describe the most common congenital conditions affecting the newborn, compare and contrast the 4 classifications of congenital heart disease, distinguish 4 inborn errors of metabolism, describe the most common acquired conditions affecting the newborn, outline the assessment and nursing management needed for newborn sustaining birth injury, plan the assessment, interventions, prevention, and management of hyperbilirubinemia in newborns, examine the impact of maternal diabetes on the newborn and the care needed, research the assessment and interventions for a newborn experiencing substance withdrawal after birth, summarize the interventions appropriate for a newborn with neonatal sepsis, plan the nursing management of a newborn experiencing respiratory distress syndrome, outline the birthing room preparation and procedures necessary to prevent meconium aspiration syndrome or MAS in the newborn at birth, devise parent education for the follow-up care needed by newborns with retinopathy of prematurity or ROP, identify risk factors for the development of necrotizing enterocolitis or NEC. Evaluate the major congenital and acquired anomalies affecting the central nervous system, respiratory system, gastrointestinal system, genitourinary system, and musculoskeletal system that can occur in the newborn. Characterize the importance of parental participation in care of the newborn with an acquired or congenital condition, including the nurse's role in facilitating parental involvement. So when you look at these disease processes or conditions within the newborn, we break them up into acquired disorders versus congenital disorders. So with acquired disorders, they typically occur at or you'll see symptoms soon after birth. Problems or conditions experienced by the birthing patient during their pregnancy or at birth could impact this with acquired disorders, and possibly no identifiable cause for the disorder would be determined. Now, it's a little different with congenital disorders because those disorders are they occur during development in utero. So the baby is born with the condition, and that means that it's present at birth. And so even if you don't exactly see the problem at birth, it can be traced back with testing for some of these disorders that it is congenital. So it's usually due to some type of malformation occurring during the antenatal period, and typically some sort of problem with inheritance patterns. The majority of congenital disorders has quite complex etiology behind it. So we're going to start with congenital conditions, and these conditions include disorders that fall in the category of neural tube defects, even microcephaly, hydrocephalus, choanal atresia, congenital diaphragmatic hernia, cleft lip and palate, congenital heart disease, esophageal atresia, and tracheoesophageal fistula, omphalocele and gastroschisis, imperforate anus, hypospadias and epispadias, bladder exstrophy, congenital clubfoot, and developmental dysplasia of the hip. So, 4 physiologic categories of congenital heart disease that you need to be aware of include defects causing increased pulmonary blood flow, So that could be an atrial or ventricular septal defect. So with an ASD or atrial septal defect, that would be like a hole in between the atria. Ventricular septal defect would be a hole between the ventricles. Defects causing obstructed blood flow out of the heart include aortic stenosis. Defects causing increased blood flow, or not increased, excuse me, but decreased blood flow. Defects causing decreased blood flow include tetralogy of Fallot. Tetralogy of Fallot is made up of 4 different cardiac anomalies, and because of this, these babies tend to be your blue babies, your cyanotic babies. They'll often have TET spells, or hypercyanotic spells that typically when we see that occurring, we can put the baby in knee chest position, and that will actually help with the TET spell because of the way it forces the oxygenation and the oxygenated blood to flow. Now, defects involving mixed blood will be, it'll have desaturated or saturated. So, again, just pay attention to these different physiologic categories. Now, how are these managed? Well, typically it is done with medications, surgeries. Sometimes it requires multiple surgeries, making these babies have to wait to where that they may go into heart failure before they even get all the surgeries completed. So they may need additional help. So, like this little baby that's on the very far right picture, who you can tell has had the cardiac surgery, has a little scar there, and it has actually a ventricular assist device or a VAD device called a Berlin heart that's actually helping that baby. So this baby right here is waiting on a heart transplant. Just so once it gets the heart transplant, they'll take that VAD away, and it shouldn't need that anymore. So what are some of the risk factors? So there's quite a few actually. Birthing parents who misuse alcohol, who has diabetes, who have a gene mutation or chromosomal disorder, who are exposed to x-rays, exposure to rubella infection, poor nutrition, being over 40, use of amphetamines. There are genetic factors, birthing parent with a metabolic disorder of phenylketonuria, and of course, use of anticonvulsant, estrogen, progesterone, lithium, morphine, or isotretinoin therapies. So other things to manage include assisting with lab tests like getting arterial blood gases, chest x-rays, MRI, ECG or EKG, blood studies, echocardiogram. We also need to be aware that we need to provide preventative prenatal care during this time. These little ones are going to get continuous monitoring of cardiac and respiratory status. We would need to administer any ordered medications as per the provider's orders, and provide lots of education and counseling to the parents on the condition and the medical plan. Any follow-up with the providers or any specialists that need to be done. So that becomes very important. And of course, any kind of pre, intra, or post-op care for surgery. So neural tube defects, we typically see neural tube defects a lot due to a deficiency of folic acid, and these are congenital CNS disorders, and it occurs when the neural tube fails to develop or close properly. And you normally see that occur between the 17th and 30th day of gestation. So there are some different kinds of defects that fall under neural tube defects. And the first one I want to talk about is anencephaly. Anencephaly is one of the most severe fatal neural tube defects. It results from the failure of the neural tube to fuse in the cranial area, with the cerebral hemispheres completely missing or reduced to small masses. The brain's replaced by an undifferentiated mass of connective tissue and vessels. It most commonly involves the forebrain and variable amounts of the upper brainstem, where there's no brain tissue above the brainstem. Infants with this disorder are born without a brain front and a cerebrum, with the rest of the brain tissue exposed without bone or skin covering. So that is the far left picture under the heading neural tube defects is what you're seeing is anencephaly. These little ones, depending on how much brain they have, is going to be depend on how long they'll actually live. Sometimes they only live for a few hours, other times they live for longer. Now, we also have the spina bifida disorders. So, spina bifida occulta is the mildest form, where there's a small gap in the spine but no opening or sac on the back. It often may not cause symptoms or disabilities, but it is important to see a pediatric neurosurgeon because sometimes these little clients can have tethered cords or other spinal anomalies that can cause problems later in life. So the three pictures here at the bottom of this slide shows you some of the signs and symptoms, the clinical manifestations of spina bifida occulta. You can see kind of a closed protruding bump there at the sacral area, or a large tuft of hair, or even sacral dimples that could be closed or open. Now, one thing I'm going to tell you about sacral dimples is just because a baby has a sacral dimple does not mean that they have spina bifida occulta. So just please be very aware of that. Now, a meningocele falls under the spina bifida disorders. It's a rare form where a fluid-filled sac protrudes through the spine, but the spinal cord is not in that sac. These little ones may have some minor disabilities that we need to be aware of. And then myelomeningocele is the most severe form. Now, there is in the spinal canal, there is that opening along several vertebrae in the back that allows the spinal cord and membranes and nerves to protrude into that sac. So this can absolutely result in significant disabilities to the baby, bowel, bladder problems, paralysis, things like that. So surgery to repair the defect is most often performed in the first few days of life to try to minimize any long-term problems and to decrease the chance of, especially if it's an open sac, to decrease the chance of infection or anything like that. So figure 24.1 is your far left picture. This comes straight out of your book. A gives you a good photo of, or a good picture of the normal spine. B shows you spina bifida occulta. So you don't really see much. It's just kind of that open area there, but there's no fluid fill or spine and nerve contents in a sac or anything. C shows you the meningocele. So you definitely can see that the spine and nerves and things are not inside that sac. And then you have D, which shows you a myelomeningocele. So with these disorders, especially a myelomeningocele, it's not uncommon to see those babies develop hydrocephalus. So just be aware of that as well. The top middle picture is a closed meningocele. The bottom middle picture is a myelomeningocele. The top right picture shows a meningocele that's actually, because it can be located anywhere along the spine, not just the sacral area, and that one's located right there close to the nape of the neck. And then the bottom right picture shows you a myelomeningocele with an open area on it, which that would need to be surgically taken care of very quickly. Microcephaly, the word itself just means small head. So it's a rare condition where the child has a small head. The head circumference is usually more than 2 standard deviations below the mean for that age and sex of that baby. This can be primary microcephaly or it can be secondary. So primary, the baby has it at birth. Secondary, it develops later because of another issue. Risk factors for microcephaly include genetic syndromes, intrauterine infection like cytomegalovirus, herpes simplex virus, HIV, rubella, syphilis, toxoplasmosis, and Zika virus. Other risk factors include hypoxia, radiation to the maternal pelvis in the first or second trimester, maternal phenylketonuria or PKU, maternal hypothyroidism, and maternal alcohol or cocaine use. These little ones have neurologic issues and developmental delays because of the fact that their brains are smaller than the usual brain size. Having a smaller head like that doesn't allow for the brain to grow and develop like it normally would. So there are not any curative things we can do for babies with microcephaly. The only treatments we can do are supportive in nature. So we're going to focus on decreasing the impact of the deformities and disabilities, provide lots of supportive care, and these little ones will be referred out to speech PTOT. They're going to get all the things. Provide lots of education to the parents, and of course, appropriate community referrals is warranted. But as with any condition with a child, especially when we know it could cause cognitive or developmental delays, we need to start early with treatment. The earlier treatment started, usually the better quality of life these little ones can have. Hydrocephalus is an increase in the cerebral spinal fluid in the brain, and it's usually due to either overproduction of CSF or impaired circulation and absorption, which could be an obstructive issue. This causes the CSF to accumulate in the ventricles of the brain and swell. Those ventricles will swell up, and that results in tissue compression and increased intracranial pressure. Now, hydrocephalus can be congenital or it can be an acquired condition. And how can it be acquired? Well, just like I told you about the meningocele. That is going to be the congenital condition the child has, but because of that, they have acquired hydrocephalus as a result from their congenital neural tube defect. So just be aware of that. Diagnostics that can be done to confirm the diagnosis of hydrocephalus include a CT scan or MRI and How it's treated, it could be treated a couple different ways. Um, Surgery to insert a ventriculoperitoneal or VP shunt can be done, or an external ventriculostomy, ETV, could be done. So, nursing care and management, your assessment is going to focus on obtaining a good health history and performing a good physical examination. Be alert for any risk factors in the maternal history, such as intrauterine infection or preterm birth. You're going to assess the infant's head circumference and note any increases. And so those head circumference assessments will be done every shift. Also note any visible scalp veins. And of course, you can see in figure 24.3 where they're shining a light through the baby's head, and you can see the little scalp veins there with that light shining through. You need to palpate the infant's head, noting any widened sutures and wide open fontanelles. And you need to take note about what the fontanelles palpate as or what they feel like. Often they're going to feel very tense and bulging, so very tight and bulging. Observe for other signs of increased intracranial pressure, including poor feeding, sunsetting eyes, and vomiting, lethargy, and irritability. So hydrocephalus stops that cerebral spinal fluid from moving out of the cranium. And our goal is to release the pressure on the brain and drain the CSF. Because if we don't, that pressure on the brain will ultimately cause brain damage. So that's what your concept mastery alert from your chapter is talking about. And it tells you about the two different procedures that we can do, and that the success of that depends on the child's age, the cause of a hydrocephalus, and any history of previous complications. We also want to do head protection to prevent skin breakdown. And surgical care is going to include our pre, intra, and post-operative care, and we're going to provide lots of education to the parents and support as well. Choanal atresia is the narrowing of the nasal airway due to a membranous or bony tissue. It's an uncommon congenital malformation. It can be unilateral or bilateral, but if it is bilateral, that means your newborn is going to be unable to breathe. And newborns are obligatory nose breathers. So if a baby has bilateral choanal atresia, establishing an airway is your emergency priority. Choanal atresia typically presents with other anomalies involving the heart or the central nervous system. Females tend to be more affected than males. If we have bilateral choanal atresia, during attempted inspiration, the tongue's going to be pulled to the palate, and the oral airway becomes obstructed just as bad as the nasal airway. If the infant will cry and it'll take a big breath through the mouth, that momentarily relieves the obstruction. But when crying stops, the mouth's going to close, and then the cycle of obstructions repeated. So if we remain this way without any surgical intervention, death from asphyxia can occur at birth. So surgery is needed to remove the obstruction and to establish a patent airway, and full recovery is usually the outcome from this. Congenital diaphragmatic hernia is a severe anomaly where there's a failed full development of the diaphragm. This can be associated with hydramnios or polyhydramnios in utero, meaning there's too much amniotic fluid. It's majority are typically detected via ultrasound in the prenatal period. Remember, our ultrasounds have gotten very intricate with the 3D, 4D ultrasounds, so they're able to catch a whole lot more things nowadays that they couldn't catch before. Assessment and management. Obviously, with a diaphragmatic hernia, we're going to be paying attention to their airway and any issues with their breathing. And these little ones are going to need to have surgery. Cleft lip and cleft palate involves a fissure or an opening in the lip or the roof of the mouth. So cleft lip has that fissure in the lip. It could be to varying degrees from a small fissure or one that goes all the way up through the nose. Cleft palate, the fissure or the hole in the roof of the mouth could be as small as a pinpoint hole or it could be rather large. But cleft lip and palate tend to be the most common craniofacial birth defects. And repairing the facial anomaly as soon as possible is important to facilitate bonding between the newborn and the parents and to improve nutritional status. Treatment of cleft lip occurs via surgical repair between 6 and 12 weeks of age. Cleft palate surgical repairs between 6 and 18 months of age. Usually for cleft lip, successful surgery often leaves only a thin scar on the upper lip, but the outcome of the surgery truly depends on the severity of the defect. Children with more severe cases will need additional surgeries in stages. Now, until surgical repair of a cleft palate is done, a plastic palate guard or palatal obturator is actually fitted and used. It's a form of synthetic palate that gets placed up in the palate to where it will actually cover the cleft palate over and allow for the introduction of oral fluids and foods and prevent aspiration in the interim. Many infants with cleft lip and cleft palate cannot be breastfed or breastfed easily. Those with cleft palate, they cannot produce a good negative pressure that's necessary just to suck for that suction. Infants with a unilateral cleft lip could potentially succeed with breastfeeding as long as they are positioned to where the lip is obstructed by the breast tissue. So, truthfully, no single feeding method has been identified as ideal. We just have to work with the parents and the providers to figure out what's going to be the best method for that infant. We need to promote adequate nutrition and ensure that the baby is getting what they need. So if they're getting breast milk, they may actually get a powder put in the breast milk to increase the calories and nutrients of the breast milk for the baby. If they're on formula, they're going to get a high calorie formula. These little ones need to be fed in an upright prevention to prevent aspiration and to achieve adequate suction during the feeding. The infants need to be burped frequently to reduce risk for vomiting and aspiration. And they need to be burped in the sitting position on the lap to prevent trauma to the mouth if we avoid putting them over the shoulder because that could cause trauma to the mouth. We need to limit feeding session times to avoid poor weight gain due to fatigue. So if they are able to breastfeed, it's going to look like putting the baby on the breast like 10 to 20 minutes per breast, not 20 to 30 minutes. And the provider may want the baby to have some additional donor milk or pumped milk or formula because these little ones are prone to poor weight gain due to fatigue, and that's what we're trying to avoid. After feeding, the baby needs to be positioned on their side with the head of the bed elevated, or they can be positioned on their side in an infant seat. Um, and then we need to provide lots of education to the parents about, feeding sessions, what to expect, follow-up care, things like that, and promote bonding. With the use of our upgraded ultrasounds over the years, cleft lip and cleft palate may be diagnosed prenatally via ultrasound after 13 to 14 weeks gestation, or somewhere between there and the 20th week. And so, if the client's able to see that ahead of time, they're able to get a better understanding and acceptance of the malformation, gives them time to prep for the birth and to sort of have a plan in place for what things may look like with this little one. We need to develop interventions as nurses to help the parents deal with the impact of the potential social stigmatization and physical concern, the cleft lip and palate condition. Sometimes parents get upset with the appearance of their newborn. It's just not what they expected. And sometimes it's more so being upset with themselves and thinking they did something wrong when really they didn't, or they didn't have any control over it. So we need to encourage the parents to express their feelings about this very highly visible anomaly. And as the nurse, you can help by emphasizing the newborn's positive features and, oh, look at those beautiful eyelashes. Oh my gosh, your baby is so sweet. Look at all that hair. Really emphasize those positive features and role model nurturing behaviors when you interact with the infant. Look at the infant in the face, talk to the baby. Be the parent's role model so you can show them how easy it is to interact and see through that anomaly and realize that it's going to get fixed one day. Right now, in the interim, we've still got to provide love, support, and safety to our little baby. Now, when these babies have feeding difficulties, parents can get frustrated too. So it's good just to allow the parents to vent their frustrations to you and offer them practical suggestions and continued encouragement for their efforts. Give them praise for every positive step that they make. The impact on the quality of life for the infant and the family can be severe, especially if they're not prepared for it. The emotional and psychological needs need to be recognized and addressed. And of course, we're going to address, the surgical care and what they can expect when the time comes for that. We need to outline the different treatment modalities and explain the staging of surgical interventions to them. And it can be helpful to show photos taken of before and after surgical repairs, so that can help alleviate some of their anxieties on what to expect. We're always, always, always planning for discharge as soon as the patient hits our door. So, discharge will occur at some point for these babies. So we have to get these parents to a space to where they could feel comfortable doing the infant care, provide them with anticipatory guidance and any instructions for potential challenges that they could face at home or in the near future, which could include feeding difficulties, frequent ear infections, speech difficulties, and dental problems. And then obviously we're going to put them in touch with the appropriate community support, referrals, and counseling as needed. But we as nurses can help the parents to trust in themselves and feel confident in their ability to love and nurture and care for their newborns by just actively listening, providing education, information, and lots of encouragement and role modeling for them. So this is a picture of a cleft palate, and then on the top right, um, sometimes they're not that evident, and sometimes you can only see them. You may not be able to palpate. That one you'll be able to palpate without looking. But sometimes they're so small that your finger will rub right over it and you don't palpate it, but you can see it when the baby opens its mouth to yawn or cry. The bottom two pictures below that cleft palate shows the palatal obturator. Um, that is used for feedings to place a seal over the cleft palate. And then the top right shows a Haberman bottle that the baby is feeding on. And it's a bottle specifically made for babies and infants with cleft lip and cleft palate. Um, And so you can see there's on the picture below that with the blue background, there's a couple of Haberman feeders. There's another type feeder that kind of reminds you of a spoon. Then there's three different devices that can be used with either finger feeding or breastfeeding. Esophageal atresia and tracheoesophageal fistula. So there is a lack of normal separation of the esophagus and trachea during embryonic development that occurs. Esophageal atresia is a congenitally interrupted esophagus. It's going to end up being like a blind pouch. A tracheoesophageal fistula is an abnormal communication between the trachea and the esophagus. So, what tends to happen is you may find that it could be one or the other, but oftentimes it's both. Nursing assessment, one of the major risk factors we find in pregnancy is hydramnios. On assessment, our babies can have copious, frothy bubbling of mucus and drooling and abdominal distension. They will oftentimes have coughing and choking episodes and cyanosis, especially with their feedings. Okay, so these little ones are going to get prepped for surgery and preoperative care. We're going to make them NPO or nothing by mouth, elevate the head of their little bed, provide hydration and IV fluids through an IV line, have oxygen and suctioning equipment available, provide comfort measures pre and post surgery, provide lots of parental education, including post operative care, because these little ones are going to be getting total parenteral nutrition or TPN and antibiotics for around the first week. And then after or within a week or so, oral feedings will slowly begin. Now, concept mastery alert in your book is just a reminder that esophageal atresia has a very high risk for respiratory distress, and many with EA also have TEF. So that puts the newborn at super high risk for respiratory distress, especially when attempted to be fed by mouth. So we have to be very aware of that. Omphalocele and gastroschisis. Omphalocele is an umbilical ring defect with evisceration of the abdominal contents in the external peritoneal sac. So those contents will spill into the umbilical cord. That's the far left picture. That's an omphalocele. Gastroschisis is the herniation of abdominal contents, so the abdominal wall defect. There's no peritoneal sac there. So that is the picture on the right on this slide. We're going to be looking at the risk factors. Look for the protrusion of the abdominal contents. Is there a sac present? Are there any other obvious congenital anomalies? And also, we may need to be doing some testing for those other congenital anomalies. If the baby has these, we need to ensure that Um, what's herniated out of the abdomen and that umbilical cord itself stays moist, where the gastric contents are. Um, we're going to provide preoperative care by preventing hypothermia, maintain perfusion to all the abdominal contents, protect any that's exposed from trauma and infection, prevent intestinal distension, and maintain fluid and electrolyte balance through IV site. We're going to provide postoperative care, monitor for signs and symptoms of infection, ensure that the baby stays in a neutral thermal environment, the blood sugar's good, and help to promote parent-newborn interaction um, as much as possible within the constraints or limits that are at that moment. Imperforate anus is where the rectum ends in a blind pouch or fistulas between the rectum and perineum. Nursing assessment is going to include the absence of an anal opening. There's not going to be any passage of meconium, and there may be signs and symptoms of intestinal obstruction. These little ones have to have an anal opening right there, so we're going to prep them for surgery, and that surgery looks kind of brutal on creating an opening. So you're going to provide lots of postoperative and comfort care once the baby's out of surgery, lots of education to the parents, monitor for signs and symptoms of infection, and make sure that the baby doesn't have any active intestinal obstruction or ileus or anything like that. Spadias is the abnormal positioning of the urinary meatus on the other side, underside or ventral side of the penis or glands. When a child has hypospadias, they could also have scrotal and testicular anomalies as well. Hypospadias occurs as a result of the urethral folds failing to partially or completely close with the lack of fusion of the foreskin. The cause is generally unknown, but it's thought to be influenced by genetic and environmental factors. Risk factors include maternal diabetes, placental insufficiency, prematurity, fetal growth restriction, advanced maternal age, and in vitro fertilization. It is a relatively common malformation of the penis. We typically delay circumcision because the foreskin is needed to do the surgical repair. That's typically completed between 6 and 18 months of age. Now, epispadias is a rare defect and refers to where the urinary meatal opening is being located on the dorsal surface of the penile shaft or glands, and it can be associated with bladder exstrophy. The degree of hypospadias or epispadias depends on the location of the opening. It is often accompanied by a downward bowing of the penis or chordae, which can lead to urination and erection problems and infertility in adulthood. So it doesn't matter if it's epispadias or hypospadias, circumcision should be delayed so that the foreskin can continue to develop and have enough foreskin to be used to surgically correct the anomaly. We want to limit psychological stress on these babies, so that's why surgery is completed typically between 6 and 18 months of age. Bladder exstrophy is the protrusion of the bladder onto the abdominal wall. There's a separation of the rectus muscles and the symphysis pubis that allows that to occur. Males also will have epispadias. Initial bladder closure should occur within 48 hours after birth, and further reconstruction should occur between ages of 2 to 3 years of age. Congenital clubfoot is a common congenital developmental deformity where the foot is excessively turned in and non-flexible. So the foot's going to appear turned in and down. It's usually smaller than a normal foot with a soft, flexible heel because of the hypoplastic or underdeveloped calcaneus. The heel is internally rotated, making the soles of the feet, if it's bilateral, face each other. Four components of congenital clubfoot can be seen. Inversion of the heel, plantar flexion of the foot, and the heel's raised and would not strike the ground in a standing position. Plantar flexion of the forefoot on the hind foot, that's called cavus. Forefoot inversion with slightly upward turning, so that's forefoot adduction with supination. How we treat this is with serial casting, and if that doesn't work, surgery. So the management of clubfoot needs to begin shortly after birth. Casts are initially changed every 5 to 7 days and are continued to be applied and changed out until the deformity responds and is fully corrected. So you can see in the picture I provided you that this is clubfoot treatment over 4 to 6 weeks, and you can see the progression from the far left from at birth all the way till the baby was 4 to 6 weeks of age after having the serial casting done. Now, if full correction does not occur with casting, surgery and bracing may become necessary. And that surgical intervention will usually occur between ages 4 and 9 months of age. Management focuses on cast care, skin integrity, maintenance, and education of the parents. The parents need to understand about the newborn's condition and the treatment protocol so that will reduce their anxiety and provide reassurance that the baby's not in pain because of the clubfoot and it won't hinder their development as long as it's treated appropriately. There may be challenges associated with sleep, play, and dressing, so the parents need to be aware of that. Slight modifications may need to be necessary to accommodate the plaster cast when it comes to their clothing and positioning. So you're going to need to review positioning, bathing, and skincare along with pain management when new casts are applied. Make sure and stress the need to provide a calm, quiet environment to promote relaxation and sleep for the newborn. Developmental dysplasia of the hip is an abnormal growth or development of the hip that results in instability and allows the femoral head to become easily displaced from the acetabulum. Early diagnosis and treatment can help prevent long-term complications such as persistent dislocation and early hip osteoarthritis. So these little ones can have hips that are unstable, subluxated, or dislocated, or even have a malformed acetabulum. The etiology of this is unclear, but we do know that certain risk factors may be involved, such as certain racial backgrounds like Native American, genetic transmissions where it runs in the family, intrauterine positioning like breech positions, female sex being more prone than male sex, oligohydramnios, which is too little amniotic fluid, birth order, being the firstborn more prone to it, postnatal infant carrying positions, especially when swaddling or putting in a position that forces the hips to be adducted. So on assessment, we're assessing the hips for instability. This is where you can go back to chapter 18 and look at the Ortolani and Barlow maneuvers to elicit the cessation of the dislocated hip and reduction of it. So when you do like the Barlow maneuver, a clunk is felt when the infant's legs are abducted into a frog position. Other signs you would observe for physically include asymmetric thigh or buttock skin folds, apparent or true short leg, limited hip abduction, and of course feeling that clunk on the Ortolani and Barlow maneuver checks. Treatment, obviously, an orthopedist referral will have to be done. The most widely used device for correction is the Pavlik harness, and it's worn continuously until the hip is stable, and that can take many months. If the Pavlik harness doesn't work, then surgery will be needed. Inborn errors of metabolism are biochemical genetic disorders that disrupt normal carbohydrate metabolism, protein metabolism, fatty acid oxidation, and glucose storage. Most are due to a defect in an enzyme or a transport protein, and that results in a blocked metabolic pathway. Symptoms are manifested secondary to toxic accumulation of the substances within the neonate system. Newborn screening test is done at or after 24 hours of age, but before discharge to home. If the results come back positive for any of the disease processes that it checks for, then further testing and assessment are warranted. Signs and symptoms for certain disorders could actually present before the test results are back. Examples of inborn errors of metabolism are located on table 24.1. Phenylketonuria, which is PKU, maple syrup urine disease or MSUD, galactosemia, and congenital hypothyroidism. So we manage these by providing diet or supportive therapy. These clients may need to be given enzyme or coenzyme replacement therapy. We have to remove the harmful substances from their diets. They may also need cell and organ transplantation or gene therapy. So successful outcomes for children with inborn errors of metabolism depends on early diagnosis and prompt intervention. Most inborn errors present in the newborn period with non-specific subtle manifestations: lethargy, hypotonia, respiratory distress, poor feeding, and poor weight gain, vomiting. Other clinical manifestations include developmental delay, loss of milestones, and seizures. So, if the baby is not treated appropriately, then these toxins can build up into their system and cause brain damage and death. So we have to be very careful about understanding and being aware of this as nurses and looking at those clues from the maternal history, lab work, and clinical examination. Now we're going to go into the acquired conditions of the newborn. Things that we're going to talk about include neonatal asphyxia, transient tachypnea of the newborn, respiratory distress syndrome, meconium aspiration, persistent pulmonary hypertension of the newborn, bronchopulmonary dysplasia, retinopathy of prematurity, peri and intraventricular hemorrhage, necrotizing enterocolitis, infants of diabetic birthing parents, birth trauma, newborns of perineal substance misuse of the birthing parents, and then hyperbilirubinemia and newborn infections. So the first thing we're going to start out with is birth trauma and injury. These are injuries due to the forces of labor and the birth process. This includes fractures, brachial plexus injury, cranial nerve trauma, and head trauma like cephalohematoma and caput succedaneum. So you can see table 24.2 to learn about those. So we're going to be looking for different risk factors such as fetal macrosomia. We are looking at dystocia during labor and delivery. We are looking at the maternal pelvis and if it is actually adequate to support a vaginal delivery. There's a lot of different risk factors. So We're also going to perform a good physical and neurological assessment. We're going to be looking for bruising, bumps, swelling, any kind of paralysis anywhere, and symmetry of structure and function. We provide a lot of supportive care. We're going to assess for any complications and that what's going on is resolving, provide lots of support and education, have a realistic appraisal of the situation, and provide any community referrals for ongoing follow-up and care. Bilirubinemia is the imbalance in rate of bilirubin production and elimination. So this in your book is described as a total serum bilirubin level greater than 5 milligrams per deciliter. We do in the real world upstairs, we compare their bilirubin level to their age to kind of see where it falls on that chart of how bad it is and what kind of treatment it needs to occur. Benign neonatal hyperbilirubinemia is also called physiologic jaundice. Signs and symptoms of this will occur after the first 24 hours of age. Typically, the bilirubin level will peak on the third or fourth day of life before it starts to drop to within normal limits for their age by 7 to 10 days old. This can include early onset breastfeeding jaundice and late onset breastfeeding jaundice. So, physiologic or benign neonatal hyperbilirubinemia is a normal process in our neonatal population due to excess amounts of the byproduct from the breakdown of hemoglobin and the neonate's body's insufficient ability to quickly convert the fat-soluble toxic unconjugated bilirubin to water-soluble conjugated bilirubin that can be pooped and voided out. So total serum bilirubin levels will increase high enough after 24 hours of age to manifest signs and symptoms of jaundice that include the yellowing of the skin, which should occur in a cephalocaudal developmental fashion, potential yellowing of the sclera, poor feeding, signs and symptoms of dehydration like sluggish circulation, and the baby being very sleepy. Significant hyperbilirubinemia or pathologic jaundice develops early in life, so it develops within the first 24 hours of life. So it occurs because of a pathologic reason occurring within the baby's body. For instance, dehydration paired with excessive body bruising. Pathologic significant hyperbilirubinemia. Now, this oftentimes, if not monitored appropriately and treated appropriately, can lead to bilirubin-induced neurotoxicity, where the total serum bilirubin level is greater than or equal to 25 milligrams per deciliter. If it continues to rise, these little ones can get neuro disorders like kernicterus or bilirubin encephalopathy as their total serum bilirubin levels increase to equal to or greater than 30 milligrams per deciliter. So know the risk factors, okay? Rh isoimmunization and ABO incompatibility fall under pathologic jaundice or significant hyperbilirubinemia. So does excessive body bruising, hemolytic anemia, any of the sepsis or torch infections that the baby can get. So risk factors include bruising at birth, prematurity, history of a sibling that had jaundice at birth, inadequate feedings or breastfeeding, hemolytic disease, birth injuries such as cephalohematoma, polycythemia, Down syndrome or other genetic diseases, family history of hemolytic disorder, maternal diabetes, and male sex of the baby. We are going to be assessing for the signs and symptoms of jaundice and checking the labs. So you can see on the far left picture, the bottom right picture, which is labeled C, actually shows you a person blanching the skin of a newborn, and that newborn's actual skin tone when it's blanched is normal for its ethnicity. But if you look up above that, when the skin of another newborn is blanched, it's yellow. It has that yellow undertone. So that leads me to have you look at the baby that shows you the picture from head to toe. You can tell that baby is yellow orange, and you can see like her vaginal area and that labial area is kind of ruddy red in color, but the rest of her is very yellow from head to toe. So it would be quite likely that if we were to look at the sclera, the whites of her eyes, they would be yellow too. Lab tests that we may get. So when a baby's born, especially if the baby's mother is um, RH negative, we're going to get a direct Coombs test, and that direct Coombs or DAT test, tests it detects maternal IgG antibodies in the baby's blood to help ID hemolytic disease of the newborn, which occurs with Rh isoimmunization in utero. So, newborns' red blood cells are being sensitized by being coated with the antibodies due to the mother's immune system destroying the baby's red blood cells. So, that's what you see with Rh incompatibility. Now, we like to see that negative, but if there's IgG antibodies present, then it's going to be positive. And so we can deduce from that being positive that that neonate may require further, more frequent testing and phototherapy earlier in age versus later. We look at the hemoglobin concentration to check for anemia, the total serum protein to detect if there's reduced binding capacity of albumin, the reticulocyte count to help ID if there's increased hemolysis occurring, because if there is, it's going to show as an elevated level. Transcutaneous bilirubin level is a non-invasive, instantaneous point-of-care testing that is ordered by the provider and completed by the nurse. It uses optical spectroscopy light to detect bilirubin levels through the skin. And then, of course, we can always get a serum bilirubin level through a capillary heel stick or a venous stick. And with that, you can get the total amount of bilirubin, the direct or the indirect bilirubin levels, which tells you the conjugated versus the unconjugated levels in the blood. So how do we manage it? Well, we need to reduce the bilirubin levels. And so we need to institute early feedings, ensure that the baby is peeing and pooping appropriately, and that the meconium stool is changing from meconium to the milk stool. If the level is high enough, the child may need phototherapy with the neo blue lights or a billy blanket. And if that is not working or it gets back, the bilirubin level gets high enough, an exchange transfusion may have to be done. We need to provide lots of education and support to the family. They're typically not prepared to have to stay for extra days in the hospital or for their baby to have to stay extra days in the hospital to have jaundice therapy. And of course, sometimes the provider feels good enough to allow them to go home and maybe even have some home phototherapy done where a billy blanket is brought by pediatric home health to the home and then getting serial bilirubin levels drawn outpatient. So you need to see Teaching Guidelines 24.1 in your book. Infants of birthing parents with diabetes. So the high levels of maternal glucose crosses the placenta, and that stimulates our fetus to increase their insulin production, which leads to that somatic, really big fetal growth, our big babies. Nursing assessment, we are going to be aware of the birthing parent with diabetes and how well controlled it is and what they're using to control it, whether it's diet controlled or they use medication to control it. On assessment, these little ones will have full rosy cheeks, a ruddy skin color due to polycythemia, a short neck with a buffalo hump back there because of the big old fat pad, massive shoulders, distended upper abdomen, excessive subcutaneous fat tissue, and they can suffer from hypoglycemia, birth trauma, hypocalcemia, hypomagnesemia, and hyperbilirubinemia. So, these little ones can also be prone to respiratory problems as well as thermoregulation issues. So, our best way to combat this is to prevent hypoglycemia by providing the oral feedings like we're supposed to, provide a neutral thermal environment, and give the baby rest periods, so cluster their care. Hypoglycemia can occur as early as immediately at birth or within an hour after birth. Your table 24.4 gives you clinical laboratory values for infants of mother with diabetes. So hypoglycemia in the newborn is less than 50 milligrams per deciliter. Now the AAP has a level below 40, but your book says below 50. So that's what you need to go by for testing purposes. You need to closely assess the newborn for signs of hypoglycemia, including listlessness, hypotonia, apathy, poor feeding, apneic episodes with a drop in oxygen saturation, weak or high-pitched cry, cyanosis, temperature instability, pallor, sweating, tremors, irritability, and seizures. These babies may have that ruddy red skin color due to the polycythemia. You need to assess their respiratory rate and work of breathing because they're at risk for developing transient tachypnea of the newborn and respiratory distress syndrome. Perform a thorough cardiovascular assessment because these little ones are prone to cardiac congenital anomalies. Assess them for signs of birth trauma involving the head, which could feel like tense or bulging fontanelles, or even seeing a cephalohematoma, facial nerve paralysis, and even skull fractures. Shoulders and extremities for clavicle fracture, posturing, and paralysis, and bruising on the skin. Take the newborn's temperature frequently. And treatment's going to include correcting hypoglycemia and hypocalcemia, providing phototherapy for jaundice, administering fluid therapy when it's needed, maintaining oxygen and ventilation if required. If the baby has cold stress, then that increases glucose utilization and contributes to furthering the hypoglycemic state. So providing that neutral thermal environment is so important. Frequent feedings with breast milk or formula, so every 2 to 3 hours, that's going to help control glucose levels, reduce the hematocrit, and promote bilirubin excretion. Maintaining that neutral thermal environment helps to avoid cold stress. Providing rest periods decreases the energy demand and expenditure. Monitoring the blood glucose levels helps you to determine if the stability of their blood glucose and if they're having any issues. And of course, documenting their results and reporting any unstable glucose values to the provider. Oral dextrose gel can be given in the buccal pouch of the cheek to help combat hypoglycemia. But if their blood sugar level is too low to be able to use that, then IV glucose infusion will be ordered. maintaining fluid and electrolyte balance and monitoring the serum calcium level for any changes indicates a need for supplementation, such as with oral or IV calcium gluconate. And of course, we want to ensure that they're properly hydrated and provide lots of support and education to the parents. Newborns of birthing parents with substance use disorders. So the most common substances we typically see include tobacco, alcohol, and marijuana. But substances that do get misused and lead to addiction include opiates, so amphetamines and methamphetamine, also barbiturates and things like that. The first thing we're going to really hit on is fetal alcohol syndrome. So these little ones have this physical and mental disorder appearing at birth and remains problematic throughout the child's life due to the abundance of alcohol that's used by the birthing parent. It falls in the line of fetal alcohol spectrum disorders. And these pictures give you some good alcohol related clinical manifestations and birth defects. So, some of the facial characteristics include small eye openings, a smooth philtrum or area between the top lip and the nose, and a thin upper lip. Now, neonatal abstinence syndrome is drug dependency in the fetus acquired in utero manifested by neurologic and physical behaviors. So, upon your nursing assessment, you are going to potentially see the baby show behaviors of withdrawal from when you assess the baby, like excessive sneezing, poor sucking, CNS irritability, excessive yawning, seizures, um, excessive crying, tremors of the upper and lower extremities, deep increased muscle tone, GI dysfunction, things like that. So we actually do have a neonatal abstinence scoring system that we use and score our babies on, and that helps to guide the provider and whether or not we need to treat the newborn with medications. Otherwise, we're going to provide comfort promotion and reduce stimuli to the baby, ensure the baby's getting adequate nutrition, try to prevent any complications with the baby. These babies, because of their hypertonicity and their excessive crying, they are very prone, and of course the GI dysfunction, they are very prone to getting excoriation of their skin, like around their chin, their elbows, their knees, and in the diaper area. And then monitor parent and newborn interactions. So you need to see Teaching Guidelines 24.1 on page 800 in your book. So here is just a little reminder about NAS or neonatal abstinence syndrome and what types of clinical manifestations you'll see. And of course, we can treat it with morphine sulfate, phenobarbital, methadone, buprenorphine. It can also be, we could give Ativan and other medications if needed. Neonatal sepsis includes any bacterial, fungal, or viral microorganism or their toxins in the blood or other tissues. Early onset neonatal infections acquired by vertical transmission from mom to baby shortly before or during the birthing period. So that would include transplacental infections, ascending infection from the cervix, or transmission during the birth process due to overcolonization of the birthing parent's genital urinary tract and birth canal. So the most common cause of bacterial Sepsis include group B strep and Escherichia coli or E. coli, followed by Staph aureus and Listeria. So congenital is intrauterine infections, early onsets, the perinatal period, and late onset occurs after the baby's born. Non-bacterial problems that can cause and microorganisms that can cause infection include HSV, Candida, enterovirus, and pericovirus. Risk factors include a rupture membrane greater than 18 hours, maternal intrapartum fever, chorioamnionitis, prematurity, and low birth weight in the babies. These babies just look sick or not right. Their color is usually off. They have clinical manifestations of irritability, temperature instability, poor feeding, lethargy, poor muscle tone, decreased movement, seizures, respiratory distress, cyanosis, tachy or bradycardia, vomiting, diarrhea, abdominal distension, jaundice, rash, petechiae, and late signs of sepsis include poor perfusion and hypotension. So, diagnostics that can be done include radiographs like chest or abdominal x ray, a CBC with differential to identify anemia, leukocytosis, or leukopenia. We also look at the segs and bands in the differential because if the bands are high, then we know the body is pumping out immature white blood cells to fight a stressor like infection or inflammation. The C-reactive protein or CRP will be elevated, and that points to inflammation. We're going to get blood cultures before any antibiotics are started. And so we're going to have to wait on the blood cultures to come back to know if the normal antibiotics that we start with will cover whatever is happening with the baby, or do we need to make a change? And then you possibly may need to assist the provider with obtaining a cerebral spinal fluid specimen for analysis through a lumbar puncture. We may also need to get a UA with a culture and sensitivity. Now, the typical antibiotics that we start our neonatal population out on is ampicillin and gentamicin. And of course, once we get the blood culture results back, the provider may decide to change the antibiotics according to what grows on that culture. These babies go to the NICU for treatment and get round-the-clock care and monitoring. And as you can see in the baby on the far left picture, it just looks really pale. The color just doesn't look right. Now the pictures below in the white part, you have the congenital eye infection caused by gonorrhea for the two middle pictures. And then look at the little baby with the herpes skin lesions. So that's definitely something to pay attention to. So we talked a little bit about antibiotic therapy. Ampicillin is given every 12 hours. It can be given intramuscularly if needed to start, but we typically like to try to give it every 12 hours intravenously. Gentamicin is given every 24 hours, and you give it over a full hour. Each need their own appropriately labeled secondary line to administer the medication. Gentamicin requires obtaining a peak and trough serum lab level to be drawn at prescribed intervals to monitor for any toxicity, because we know that gentamicin can be toxic to their body, especially ototoxic, and cause deafness. So really early recognition of risk factors and signs and symptoms, getting an early diagnosis and providing prompt treatment is paramount for the survival of the neonate. Um, Babies who have gotten antibiotics, especially gentamicin, they're going to get an additional hearing screen before discharge, or even a referral to audiology specialist for follow-up to have it repeated, to try to ensure that the baby passes the hearing screen and that there's no issues there as the baby's being discharged. You need to continue as a nurse to provide a neutral thermal environment while the baby's on the NICU bed. They're usually on a radiant warmer bed or an enclosed giraffe warmer bed. Depending on the signs and symptoms of the neonate, feedings may be held for a certain amount of time. An OG tube may be placed if on oxygen or CPAP or ventilated intubation to keep the tummy from getting distended and eventually provide lavage feedings until improvement is seen. TPN can potentially be started if the baby's too sick for enteral feeds. We need to maintain medical asepsis when caring for the sick neonate, use proper PPE and hand washing techniques, and require all who care for or have access to visit that sick neonate to perform strict hand hygiene and medical asepsis. We need to educate the family about care and treatments while also encouraging the parents to continue to bond with the baby according to what is able to be done at that moment. Sometimes just holding the hand or the foot and just talking softly to the newborn is what needs to be done because of the irritability that it causes to the baby to be picked up and moved around. Other times, kangaroo skin to skin care can be excellent. The lights may be dimmed and the alarms may be lowered to a level to where we can still hear it, but it's not too loud for the baby's sensitive hearing. Because consistent loud alarms and bright lights are not the best for sick little ones. And we're going to cluster their care. So we're going to get everything and do everything that needs to be done at one time. Let that baby rest between scheduled care times and then repeat again at the next scheduled care time. Now, all of these pictures that I'm showing you right now is babies with congenital syphilis, and unfortunately, congenital syphilis is on the rise in our state of Tennessee, which is very scary. We went from 3 years ago, 60 cases to well over 100 cases. Well, actually, within 2 years. So from 2023 to 2025. 60 to over 100 cases of congenital syphilis. And it can cause not only these anomalies in the baby, but it can cause death, and often does, or cause stillbirth. Perinatal or neonatal asphyxia is the failure to establish adequate, sustained respirations after birth. Asphyxia is the impaired gas exchange resulting in a decrease in blood oxygen levels or hypoxemia and an excess of carbon dioxide, which is also called hypercarbia, or hypercapnia that leads to metabolic acidosis. Asphyxia is the most common clinical insult in the perinatal period and is approximately 25% of newborns who survive asphyxia at birth will develop long-term complications like cerebral palsy, intellectual disability, and some sort of speaking, hearing, visual, and or learning disability. So the pathophysiology is just simply insufficient oxygen delivery to meet the metabolic demands. So any condition that reduces oxygen delivery to the fetus, such as maternal illness or disease like diabetes, PIH, heart or kidney disease, maternal anesthesia or opioid analgesic administration, preterm delivery, multiple births, fetal anomalies, meconium aspiration syndrome, prolonged maternal labor, fetal distress or fetal heart rate category 2 or 3 tracings, intrauterine growth restriction, uh, first ever pregnancy and delivery, bloody amniotic fluid, and placental abruption are all some risk factors. You're going to be looking at the newborn's color. Oftentimes, they're right at birth, they're going to be blue or gray or even purple. And then they may continue to be cyanotic or even super duper pale. Look at their work of breathing, their heart rate, their temperature, and the APGAR scores is going to be a really quick way right after birth at 1 in 5 minutes to tell if what's going on with your baby, if it's got adequate oxygenation and or if it needs some help. So immediate resuscitation will need to be done on those babies until the APGAR score is greater than 7, and then continued observation is going to have to follow. Neutral thermal environment is very important. Checking those blood glucose levels to prevent or mitigate hypoglycemia is important. Providing parental support because they are going to be terrified at seeing and hearing what we're doing to their baby with resuscitation efforts, and providing lots of education. And of course, that's going to include any follow up care that has to be done after discharge. I included a picture of meconium stained amniotic fluid. So you can see the shiny Schultz side or the baby side of the placenta is this really weird yellowy color. When normally it doesn't look that way, and it's got some darker green patches, that's meconium stained. If this baby has meconium staining on its nail beds, of its ears, on its skin, so just be aware that if the meconium's thick and the baby sat in there in thick meconium for a period of time, that it's going to have a large amount of staining potentially on their body. Transient tachypnea of the newborn, or TTN, is truly a diagnosis of exclusion. These babies typically will show signs and symptoms of mild respiratory distress with rapid breathing or a respiratory rate over 60 breaths per minute. And the reason why this occurs is because the baby didn't get enough liquid or amniotic fluid removed from their lungs. So the pulmonary liquid removal was done too slow or incompletely. The TTN typically resolves by 72 hours of age and can resolve even sooner than that. If the birthing parent is sedated or the baby's born by cesarean section, those are some big risk factors, as well as a precipitous labor and birth, fast labor and delivery. These babies will show you signs and symptoms of tachypnea or increased breathing above 60 breaths per minute, expiratory grunting, and that sounds sometimes real light, like a sing-songy, or it can be a very obvious grunt. But it is not cute. We don't like it. It means something's wrong. Retractions in the chest, the sides, or the neck area, labored breathing, nasal flaring, and mild cyanosis. Their respiratory rates can get up to 100 to 140 breaths per minute. And during this time, their little chest may become a little barrel shaped until resolution occurs. And their breath sounds may sound slightly decreased or even wet and crackly sounding. On x-ray, you're going to see mild symmetric lung hyperaeration and prominent perihilar interstitial marks and streaks. We're going to manage this by providing baby with supplemental oxygenation, whether it is through nasal cannula or through CPAP. Supportive care, including maintaining their temperature stability, their glucose control. They're not going to be fed while they are breathing too fast because that increases the risk of, so no nipple feeding or breastfeeding while they're breathing too fast because that increases the risk of aspiration into the lungs. So they're going to get IV fluids or gavage feedings through a feeding tube, through an OG tube. So you're going to need to provide the parents with a lot of support and education. I did include this YouTube link to where you can go and look up a video of transient tachypnea of the newborn and hear grunting. So, true or false? Neonatal asphyxia commonly resolves within 72 hours after birth. That is false. Transient tachypnea of the newborn typically resolves by 72 hours of age after birth. Neonatal asphyxia requires immediate resuscitation measures, and those little ones may have lifelong complications. Respiratory distress syndrome. One of the big problems we see in our preterm clients is respiratory distress syndrome because of their lung immaturity and lack of alveolar surfactant. But we can also see respiratory distress syndrome in other clients, other gestational ages. So we're going to be looking at the risk factors. What kind of clinical manifestations are we seeing? Expiratory grunting, nasal flaring, chest wall retraction, seesaw respirations, generalized cyanosis, heart rate greater than 50 to 180, fine inspiratory crackles, tachypnea, where the respiratory rate's greater than 60, and a Silverman-Anderson index score greater than 7. Their chest x-ray is going to show hypoaeration, underexpansion of the lung, and ground glass pattern in the lung. So it's going to look like somebody just threw a clear glass down and just crushed it and ground it. And that's kind of what the pattern in the lung looks like. This is the Silverman-Anderson index, and it just gives you the features observed, and it makes you put a score with it. So, again, this is one way that helps us determine how bad our distress is, or if we're even having neonatal respiratory distress syndrome. So we need to provide supportive care and close monitoring. These babies will get ventilation through CPAP or PEEP, or they may even be intubated. If they are preterm or there's any suspicion that they don't have enough surfactant, they're going to get exogenous surfactant. So they're going to, even if they are going to get CPAP, they're going to get intubated just to get the surfactant. And then we'll monitor the baby, and then they'll start CPAP. And of course, oxygen therapy. If the baby, if they suspect any kind of infection, they're going to get blood cultures and provide antibiotics until they get the results back on those blood cultures. And if the blood culture is positive, they may resume those antibiotics, the ampicillin and gentamicin, or change it to an antibiotic that's going to cover that bacteria. If it's viral, then they're probably going to take them off the antibiotics and use other methods. And of course, we want to correct any metabolic acidosis. These babies are going to get fluids and vasopressors. They're going to have gavage or even for enteral feedings or TPN through IV. Their blood glucose levels will be monitored frequently. We're going to cluster their care. We can put these babies in a prone or a side-lying position and reposition them frequently, and we're going to provide lots of parental support and education. The parents are going to be scared and upset, and this is not what they expected. So again, we're going to have to provide lots of education and support. And anything we don't feel comfortable answering as the nurse or that we can't answer, the provider needs to be notified so that they can talk to the parents. Now, meconium aspiration syndrome is the inhalation of particulate meconium with amniotic fluid into the lungs. This occurs secondary to hypoxic stress. So we look at risk factors involved. Is this a post-term pregnancy? Is there something going on with mom that could cause stress on the baby? Things like that. The amniotic fluid is going to be stained a shade of green color. It could be light all the way to pea soup thick. Their nails, skin, and umbilical cord can also be stained. The vernix caseosa can be stained if they're preterm or if they have any vernix caseosa on them. These little ones are going to have a barrel-shaped chest, prolonged tachypnea, increased respiratory distress, intercostal retractions, and expiratory grunting and cyanosis. Their chest x-ray is going to show that patchy, fluffy infiltrate and hyperaeration with atelectasis. We're going to be getting arterial blood gases on this baby and checking for metabolic acidosis. This little one may get suctioned at birth. The provider caring for the baby may decide to use a Delis suction to suction out any excess mucus in the throat and pharyngeal area. We need to ensure adequate tissue perfusion is occurring. Decrease their oxygen demand and energy expenditure, provide a neutral thermal environment, and again, lots of parental support and education. Persistent pulmonary hypertension of the newborn is marked pulmonary hypertension causing a right to left extrapulmonary shunting and hypoxemia. On assessment, you're going to see tachypnea within 12 hours after birth, marked cyanosis, grunting, and retractions. You will be able to auscultate a systolic ejection murmur, and an echocardiogram is going to show right to left shunting of blood. We manage this by monitoring oxygenation and perfusion and blood pressure. We provide immediate resuscitation and oxygen therapy to these little ones and respiratory support. They may get medications. We're going to cluster their care and provide lots of parental support and education. So is the following true or false? The underlying problem associated with the meconium aspiration syndrome in utero involves hypoxic stress. That is true. So meconium may be passed in utero secondary to hypoxic stress. So then that increases the risk of meconium aspiration syndrome. Bronchopulmonary dysplasia is a chronic lung disease associated with newborns who have a lung injury, and they're going to need continued oxygen after their initial 28 days of life. Possible causes could include surfactant deficiency, pulmonary edema, lung immaturity, barotrauma from mechanical ventilation, and fluid overload. We're going to manage these little ones by administering steroids in the birthing parent during the antepartum period and provide exogenous surfactant to the newborn once it's born. We're going to assess for any history of risk factors like male, preterm birth, less than 32 weeks, nutrition deficiency, white or Caucasian babies, excessive fluid intake, patent ductus arteriosus, severe respiratory distress syndrome treated with mechanical ventilation for greater than a week, and sepsis. These little ones will have signs and symptoms of tachypnea, poor weight gain, tachycardia, sternal retractions, nasal flaring, and bronchospasm, where you're going to hear abnormal breath sounds like crackles and wheezing. These little ones will also have abnormal blood gas results or hypoxia. So, to manage these babies, we need to provide continuous ventilatory and oxygen support, provide optimal nutrition, administer bronchodilators, anti-inflammatory agents, and diuretics as prescribed, monitor their respiratory status, provide a high-calorie diet plan, and educate the parents and family about ongoing care, as well as any follow-up care as needed. Retinopathy of prematurity is the developmental abnormality affecting immature blood vessels of the retina. There are 5 stages from mild to severe based on the severity, location by zones in the retina, and proportion of the retinal circumference. If a newborn's premature, the vessels may cease to develop altogether. It typically develops in both eyes due to hyperoxemia. So giving high dose oxygen, or because of assisted ventilation. Also can develop due to acidosis or shock. So we need to look at prenatal risk factors, including maternal hypertension, substance misuse, preeclampsia, heavy cigarette smoking, and placental insufficiency. We need to assess the newborn's gestational age and weight, because newborns weighing less than 1,500 grams or born at 21 weeks gestation or less are at very high risk for ROP. Evaluation of the newborn's history for duration of intubation and use of oxygen therapy needs to be done, as well as monitoring for intraventricular hemorrhage and sepsis. So we have to administer oxygen therapy cautiously by using the lowest concentration and using it for the shortest duration possible. These little ones will need to have assistance for their parents in scheduling ophthalmic examinations, and they're going to have administration, the baby wheel of mydriatic eye agents 1 hour before the appointment. The baby needs to have their little eyes protected from light. And we need to provide support to the parents by giving them information and providing them details about the condition and follow-up exams. Periventricular intraventricular hemorrhage, so PVH, IVH. This is bleeding in the brain due to the fragility of the cerebral vessels. It's most commonly seen in the first 72 hours after birth, and it's graded on a 1 to 5 scale. Sometimes babies have no symptoms at all, but if the bleed continues or if it's a bad enough bleed, they can be symptomatic. So we need to be looking at any risk factors, big baby, small pelvis, dystocia. Look for any major swelling on their head when they're born, like, for instance, a large amount of caput succedaneum and a big cephalohematoma. Look for an unexpected drop in hematocrit, pallor of the skin, poor perfusion. Monitor for seizures, lethargy, weak suck, high-pitched cry, and hypotonia. We can do a cranial ultrasound to see if there are any if there's any hemorrhage and where it's at, if there is. We want to try to prevent this if at all possible. Sometimes it still will occur, especially in a preterm baby. Correction of anemia, acidosis, and hypotension needed. We need to maintain the baby in a flexed position, perform daily head circumferences, cluster their care and limit stimulation, and provide lots of support and education for possible long-term problems and sequelae um, that the parents may not be aware of because of this. Necrotizing enterocolitis. So there are three pathological mechanisms that occur. It can be bowel ischemia, bacterial flora, and the effect of feeding. Risk factors: preterm babies and sick babies are at risk. Signs and symptoms include abdominal distension and tenderness, bloody stools, feeding intolerance with bilious vomiting, sepsis, lethargy, apnea, and shock. Formula-fed babies have a higher risk of getting NEC than a breastfed baby, which is why in the preterm NICU babies, these big NICUs want to use the donor breast milk for feedings if the mother is not breastfeeding or doesn't have enough milk yet. The baby will get a KUB to check for any air in the bowel wall or dilated bowel loops. We need to maintain their fluid and nutritional status. We're going to provide bowel rest and antibiotic therapy, give them IV fluids. They will have surgery with a proximal enterostomy. We're going to provide lots of supportive care and family education through this. Which finding would the nurse expect to assess in a newborn with necrotizing enterocolitis? Is it A, pale stools, B, vigorous appetite, C, abdominal distension, or D, seizures? If you paid attention, the answer is C, abdominal distension. So a newborn with NEC would exhibit abdominal distension and tenderness with bloody stools, bilious vomiting, feeding intolerance, lethargy, sepsis, apnea, and shock. Seizures are not associated with NEC. And that concludes the end of the chapter 24. Thank you for hanging out with me and listening. Have a great rest of your day or night.